All right, well, hello everyone. By request, today I'm going to do a little mini lecture on end-tidal CO2. End-tidal CO2. So, I know you're going to hate hearing this, but this is going to be kind of a basics of end-tidal CO2 because there's more to come. Yeah, I know. But the more to come will be in things like medical, trauma, even in cardiology. We'll talk a little bit more about using end-tidal CO2 to understanding more about what's going on with your patient. So, for now, we're just going to kind of go over the basics of end-tidal CO2, look at some basic waveforms, those kind of things, and even maybe talk a little bit about compensation and seeing if our patients are actually compensating for any metabolic issues, metabolic acidosis, metabolic alkalosis, that kind of stuff. All right, so everybody knows the basics of end-tidal CO2, I think. When we look at our end-tidal CO2, X and Y axis like normal. Um, and when we talk about capnometry and capnography. So this is your capnometry. This is your capnometry. So let's say, the mid-range there is 40. So let's put more 40 right about there. Generally, what we like to see with our patients is we like to see a nice kind of a gentle upslope, nice plateau, maybe a little rise in the plateau, that's okay, and then sort of a fall off like that, okay? Um, and this is what we would consider to be right around normal. Um, I always hesitate to use the term normal because I don't really think there's any, absolute normal. But what we expect to see, I think, is sort of the norm. And so that we could maybe call normal. So excuse me, at the, at the sort of the peak of expiration, right? Here's your peak of expiration. Oh, that's a terrible. What in the world was I thinking? My God, get rid of that. So at the peak, there we go. Look at that. Nice arrow there. At the peak of expiration, okay, here's the peak of expiration, and it's what we call it the end of the tide. So end tidal CO2. Um, and so this is what we kind of expect to see. Normal expiration, and then, of course, during inspiration, our end tidal CO2 levels will drop. Um, so let's go to a different page here. So when things are not going right, and let's use red this time to sort of show when things are not going right. So let's do it. Here's our 40 again. Okay. And then let's say we have a patient where things look like this. Okay. And we could be talking about a patient with some sort of underlying disease. And let's say the value here is, let's call the value 50 at the end title there. But you notice the waveform here, and the problem with this waveform is that it sort of has the upslope is sort of, you can see how it kind of melds in there. We don't really get a good plateau. There's no real good plateau in here. All of this area in here is still on the upslope, and that tells us that that patient is constantly sort of pushing against something, and in this case, they're pushing against bronchospasm. So that's what's going on there. This patient is having a bronchospasm, and you guys all know this. You've been taught this before. You've been taught this term. You've been taught what to look for on this end tidal CO2, and we call it shark fin. Now, this is a really nice, straightforwardly defined shark fin. I mean, you can look at this and go, yeah, that looks just like a shark fin. Okay, no problem. But bronchospasm does not always look so well defined, and it's usually because of something that's going on in the patient. And we might have a shark fin that looks more like this. And you think, well, That's not much of a shark fin. No, it's not. It's not as sort of typical as this shark fin up here, but it still is, and it's still bronchospasm. And really, what I look for in my end tidal CO2 to determine whether or not this truly is shark finning is this lack of plateau, right? You can see this constant sort of upward movement, and there's really no plateau. There's just no plateau in here. And so you see the same thing here, right? Upward movement, and there's really no plateau. And so that's what I look for to really make my determination that my patient is having bronchospasm. In this case down here, in this bottom one, geez, again, I'm telling you, I can't draw arrows today. It's awful. Just awful. All right, here, I'll get a red arrow. Woohoo, yay. I guess that's not much better. Whatever. So in this case down here, you can see that your patient is not doing very well with this bronchospasm. You can tell they're not exchanging a lot of gas, and that lack of exchanging gas tells me that my patient is probably in some trouble, and that's why I need to get bronchodilators on this patient. So these patients are absolutely perfect for bronchodilators. Yeah. Bronchodilators. Yeah. Bill's having some problems spelling. It's kind of early in the morning for me, so having a little problem spelling, but you got it. Bronchodilators. D-I-A-L-A-T-O-R-S. Look at that. Yay! Okay. So these patients are perfect for bronchodilators, things like albuterol. 2.5 milligrams. We could be talking about terbutaline if we needed it. I know what you're thinking. You can spell terbutaline, but you can't spell bronchodilator? Oh, jerk. And usually with these patients, we're talking about maybe an asthma patient, a COPD patient, and Solu-Medrol is usually a good choice. Now, not saying that Solu-Medrol is curing that bronchospasm, but what Solu-Medrol is doing is it's decreasing the inflammation in the airways, and that decreases bronchospasm in total. Again, Solu-Medrol, you're probably not going to see the effects in the back of your truck. It's going to be a while before Solu-Medrol is going to work. So don't expect to see the resolution of these shark fin patterns here. Two-way. Don't expect to see the resolution of these shark fin patterns here because of Solu-Medrol. You're going to have to use these bronchodilators. And generally, I recommend that you're using albuterol. If things really get bad on these kind of patients, if things really get bad, you could be using epi. And that's your 1 to 1,000 dosage. So you're talking about epi 1 to 1,000 might be a choice if we really get bad down the line. Atrovent is perfectly fine, but Atrovent is really not a bronchodilator. Atrovent is an anticholinergic. So, a little different thing going on there, but definitely Atrovent for these patients as well. So these patients are just really good candidates for bronchodilators. All right, so let's move on to maybe what a congestive heart failure patient may look like. Ooh, I don't like that. No, I don't like it. I don't like it. Oh, what's that over there? All right, let's go to, here we go. All right. So I've got my congestive heart failure patient. And here's the thing about CHF patients is that most of them don't bronchoconstrict. Not saying that they don't. Ever. They can, obviously, because you could be talking about a patient that has both CHF and COPD, or might have some underlying causes, some other underlying causes that we'll talk about more maybe in cardiology and stuff like that, that could be causing some bronchoconstriction. So bronchodilators might be useful. However, what you generally see with your CHF patients is they sort of box off. They have this sort of boxy, what I call the pumpkin tooth look to it. Okay, so, or jack-o'-lantern tooth, I guess it would be, not pumpkin. Pumpkins don't have teeth. That would be fucking scary. Ooh, I said fuck. Sorry. Shouldn't say that. Anyway, so you have your jack-o'-lantern teeth here, right, and your CHF patients. And do these patients need albuterol? Do they need it? The answer is no. They really don't. They really don't need albuterol. They're not going to necessarily benefit from albuterol. Okay? What these patients need is CPAP and nitro. CPAP and nitroglycerin, that's what these patients need. They need to be opened up. Now, you'll notice on the end-tidal CO2 that the numbers will generally be pretty normal. They'll be pretty normal, maybe a little high, but they'll be pretty normal. But your SpO2 on the CHF patients, that's going to be pretty low. Oh, God, this is horrible. I cannot draw arrows today. Ugh. There we go. All right, your SpO2 is going to be low on those patients. So you may see a normal end-tidal CO2, but you'll see a low SpO2. And if you think about when we talked about what goes across that water barrier in your CHF patients, CO2 goes across that water barrier just fine. It's O2 that can't get back or can't get in, and that's the problem. CO2 will diffuse through that water without any problems, but O2 won't. So your SpO2 on those patients is low. Your end-tidal CO2 is normal, sometimes high. It really depends, again, on the disease process, and we can talk more about that a little later on. So this is what I generally expect to see with my CHF patients. Let me write that up here. My CHF patients on my end-tidal CO2. So, again, in the old days, we used to say, well, let's give them an albuterol and let's see if it'll open them up, quote unquote, open them up. What? I don't even know what the hell we were trying to do there. But the idea was that if they were bronchospasming, that maybe, that would open them up and get more oxygen into them. That's not really a sound idea. Most of your CHF patients are not specifically, the specific problem is not bronchospasm. Their problem is, they're drowning. So we need to deal with the drowning. We need to deal with that. CPAP, nitroglycerin. If we want to increase inotropy, ooh, yay, I drew a good one. One good way to do it, and you're probably saying it right now, is dopamine. Dopamine if necessary. Now, some people will say, well, wait a minute, Bill. If I give him dopamine, I increase his heart rate, I'm going to increase the amount of oxygen demand, right? You've heard me talk about myocardial oxygen demand. As my heart rate increases, the muscle of my heart needs more oxygen to function. That makes sense, right? And that's myocardial oxygen demand. So if I increase the inotropy and I increase the heart rate with dopamine, don't I then also increase the myocardial oxygen demand? And the answer is probably. But those problems, that problem of increased myocardial oxygen demand is offset then by this increased inotropy, okay? Because I'm getting a more efficient squeeze out of the heart, I'm actually offsetting any of the problems that I may find with increasing the heart rate. So that increase in heart rate will again be offset by that increase in inotropy. All right, so let's look at a couple of other types of end-tidal CO2. All right, we talked about this one in the classroom. This is a patient going downhill. I think it's kind of obvious. Or you need to check your equipment. Something's wrong with your equipment. But if you see this, your patient is beginning to go downhill. Okay, your patient is getting sicker and sicker, and their ability to exchange gas is decreasing. Now, this could be the ability to exchange gas respiratorily, or we could be talking about some sort of a metabolic issue. But generally, what we're talking about here generally is a respiratory issue. So they're getting worse. Now, obviously, in the reverse, if I saw something like this, yay, my patient's getting better. And you might, in fact, see this out of a like a cardiac arrest patient. You may see something like that. Wow, that's a really good arrow. I want to draw an arrow to point to that arrow. That's a really good arrow. That's nice. Anyway, so you may see, Bill's got an obsession with arrows this morning. You may see that in your cardiac arrest patients that you're getting this sort of pattern as your patient is getting better. Patterns that you really don't want to see, okay, besides that patient getting worse. But if things seem to be going along swimmingly and then all of a sudden, like, blah, 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 maybe you got a little, hold on. Let me do some erasing here, because that didn't go exactly the way I wanted it to. Kind of turned into a V-fib there, but so like all of a sudden, it's not good anymore. Okay, this is an indication that either my sensor is off, so look at your patient and see what's going on there, or my tube has become displaced. And if my endotracheal tube has become displaced, obviously that is a bad thing. Now, like I said in class, right? You ventilate the patient, you listen, you hear lung sounds, things sound fine, everything looks good, everything looks fine, your SpO2 seems fine, it's your end-tidal CO2. The end-tidal CO2 is the only thing that seems to be off. Don't just go and yank that tube out, okay? Just because you have this poor end-tidal CO2, look at what's actually going on with your patient. And if you notice that you have this poor end-tidal CO2, but everything else looks good, then try a new sensor first. Try a new end-tidal CO2 first. Those end-tidal CO2 detectors, they can get a little gummed up. So try a new one first. See if that changes. If not, and you put it back on, and the end-tidal CO2 looks exactly like this again, or worse yet, your end-tidal CO2 is looking like that. If that's what's going on, then take a look with the laryngoscope and see if it's actually in there. Again, if your patient is not getting any worse, then I venture to say it's probably still in there, and maybe the sensor on the EKG is actually bad. But usually the first problem, what it is that the tube has become displaced. It's a lot easier for that tube to become displaced than sometimes we think, and you could be looking at a problem there, obviously. All right, so we talked about this one in class as well. A little notching, could be as drastic as this. Could look any which way. But notching in the end-tidal CO2 like this. And this is your patient trying to breathe. It's possible that your paralytics are wearing off, and so you need to do that. You need to reparalyze that patient, or your sedative is wearing off, or something like that, and that's what's causing your patient to breathe against the endotracheal tube. Now, there are choices other than just saying, well, I need to reparalyze my patient. You could work with the patient respiratorily. You could actually watch when they try to breathe and then supplement that. So when they try to take a breath in, you go ahead and squeeze the bag and give them a little bit more. So you could work along with the patient instead of just saying, obviously this guy needs to be reparalyzed. So kind of, make the decision based on what you're seeing with your patient in that case. So, all right, on to, all right, so let's draw another end-tidal CO2 here. I cannot draw straight lines, and every time my hand hits the screen, one of these little guys, shows up. Oh, there he is. Oh, my God, what is that? Oh, Lord. All right, so some of the other things that we could be looking at. As far as acidosis and alkalosis goes, we kind of talked about that. So generally, when I see this really high, and let's say this is at 54, okay? It kind of looks like 64, doesn't it? Let's try that again. 50, it still didn't work. Whatever. 54, you get it. It's up there at 54. We would say that our patient is experiencing some respiratory acidosis, okay? This could be a patient who is, who you just got ROSC on. That's nice. If you see this with ROSC, oh, another good arrow. If you see this with ROSC, you should expect that your patient is probably going to do okay. So keep up what you're doing and take care of that patient and make sure that they do okay. We talked about what this is. Generally, what this is CPR. This kind of humpy shape. This actually tells me that I'm doing CPR. Usually, the number here is low, so let's say maybe it's 20 here. So that means this extends quite a ways up. But this would tell me that I'm doing CPR. That change in interthoracic pressure is what's giving me that readout on my end tidal CO2, and so this is usually indicative of CPR. Okay. Let's look at another one. So I could have something like this. And again, number 20. That means that extends up. We could be talking about hyperventilation. So this patient is hyperventilating. This is a patient we probably just need to coach and help them out and maybe keep them from hyperventilating. Again, this could be attached to other diseases as well, but right now we're really just talking respiratory. And so what they've turned themselves into, they've given themselves sort of a respiratory alkalosis, right? So respiratory acidosis back here, respiratory acidosis here. Use that red. Yay, I drew another good arrow. Respiratory acidosis here, respiratory alkalosis here. Ooh, another good arrow. I'm going to comment on every arrow, just FYI. You can, throughout this video, you can count how many times I've commented on arrows, and maybe I could make that a multiple choice test on it. No, I wouldn't do that. That would be ridiculous. Anyway, so if we're talking about a patient who has a metabolic issue, a lot of times what we see is sort of a flipped look. So if we're talking about a patient who is in metabolic acidosis, right? They're in metabolic acidosis. This up here is respiratory alkalosis. If I have a patient who is in a metabolic acidosis and is compensating, right, they will actually look like they're hyperventilating. And actually, I should change this. Hold on, because I didn't make that look quite right. They will look like they're hyperventilating, but their respiratory acidosis metabolic acidosis. They're in metabolic acidosis, and so let's say 58 is the number here, right? Geez, that's a terrible 8. 58 is the number here. And so this patient is actually acidotic, but you note that there's not a lot of space between each of these. You notice there's not a lot of space between each of those. I think 2 of those arrows are okay. But you can see your patient is, in fact, hyperventilating, but look at their number. Their number is at 58. So this tells me that my patient has some acidosis, some buildup of acid, and they're blowing that off, okay? And this will tell me that this patient is compensating. My hope is that eventually those waveforms will start to become normal waveforms, okay? Because this patient is actually compensating for that respiratory acidosis. Let's look at this, a respiratory alkalosis, okay? Or, excuse me, I keep saying respiratory, metabolic, Bill, metabolic alkalosis. And so, you may have something that looks a little bit like this. So they don't have a lot of acid, but you notice that the space between these, ooh, that's 2 good ones. You notice that the space between these is a lot bigger. And actually, if I were going to draw this correctly, I'd probably take out this center one and just make it look more like that. And so you have a patient who is in metabolic alkalosis, and so what they're doing is they're decreasing their respiratory rate in order to keep some of that carbon dioxide with them, okay, in the form of carbonic acid. So that patient, again, is compensating. That patient is compensating. This patient back here is compensating. This patient is compensating for a metabolic acidosis. Okay, metabolic acidosis. And then this patient is compensating for a metabolic alkalosis. Metabolic alkalosis. If we go back a couple of slides, and what you see here, what we're looking at is we're looking at a patient who is, in fact, this patient is dealing with respiratory acidosis, okay? And normally what we would see out of this patient is that these would extend, but they'd be kind of far apart. So you can now see the difference between this and, this one, okay? This guy right here. This guy right here, because you can see the distance between those peaks is shorter, and that tells you that your patient is dealing with a metabolic acidosis. And they're compensating. Generally, you don't see this. I mean, to be honest, you don't see a lot of metabolic alkalosis. Is it possible? Of course it is. But we don't see a lot of metabolic alkalosis. What we're more likely seeing when we're seeing a patient who's dealing with some sort of alkalosis is it's going to be a respiratory alkalosis, okay? And that means we're going to see a rapid respiratory rate, like we see here, right, from peak to peak. So rapid respiratory rate along with a very low end-tidal CO2 number. And that's going to tell me my patient is respiratory alkalosis, okay? So that's kind of the difference between respiratory alkalosis and metabolic alkalosis, and respiratory acidosis and metabolic acidosis, and what you see especially when the patient is compensating, okay? So I wanted to make sure I tried to clear that up. I hope I did. I kept saying respiratory instead of metabolic, and I think the last part here I cleared it up a little bit better. Again, it's kind of early in the morning for me. Sorry about that. So that's sort of the basics of end-tidal CO2. And what we're seeing with these patients. What you're more likely to see on the test is not things about compensating metabolic acidosis and alkalosis. You will see stuff probably about respiratory alkalosis and respiratory acidosis, respiratory stuff. And then, of course, you will definitely see different types of waveforms and different types of patterns. And I may ask, what is that pattern indicative of? Or I may ask, what's the proper treatment for this patient? Or the proper treatment for this patient may include, okay? So these kind of things, you'll see these maybe. And you'll probably see something about shark finning. I've talked about it a lot, so I wouldn't doubt that. And then normal end-tidal CO2, of course. All right. I hope that clears a few things up and doesn't make the waters any muddier. If you have any questions, feel free to ask. That'll do it for now. Take care.